rundown on conduct disorder by Annika Tracy. In order to fully conceptualize this disorder, let us first analyze a case study that presents the signs and symptoms of conduct disorder. A 7-year-old boy presents for a well child visit. He walks around the office, occasionally picking up objects or opening drawers as his mother describes his recent suspension from school for pushing other children. The boy threatened to stab another child, stole items from classmates' lunches, and is suspected of stealing money from the teacher's purse. He once left the school premises without permission, prompting a call to the police. At home, he often fights with siblings and has thrown rocks at other children. He seems to barely pay attention to the telling of his history and does not contradict any of his mother's statements. His mother reports feeling overwhelmed because of his behaviors and mentions that his father is incarcerated. She states that her relatives are taking turns coming to the home and are trying to help her control his behaviors. This child would be diagnosed with conduct disorder. Conduct disorder, or CD, is defined as a repetitive and persistent pattern of behavior which violates the rights of others or major age appropriate societal rules. Clinical features of conduct disorder would include aggression to people and animals. This child may bully, threaten, initiate physical fights, use weapons to cause harm, steal while confronting a victim, or may even have forced someone into a sexual activity. Deceitfulness or theft. This child may break into and trespass into others' homes, buildings, cars, and may often lie to obtain goods or favors or to avoid obligations, and may shoplift regularly. Serious violations of rules. This child often stays out at night far past curfew, has run away from home overnight at least once without returning for a lengthy time, and often skips school. Property destruction. This child may deliberately set things aflame with the intention of causing serious damage and may deliberately destroy others' property. All these must be seriously impair social and educational functioning in everyday life to be criteria for diagnosis. Practitioners may also want to specify if the child experiences limited prosocial emotions to best assess proper treatment routes. These kinds of characteristics may include lack of remorse or guilt. This child may show a general lack of concern about the negative consequences of their actions, callous, or a lack of empathy. This child may appear more concerned about the effects of their actions on themselves than their effects on others, even when they cause substantial harm to others, and unconcerned about performance. This child may not put forth the effort necessary to perform well, even when expectations are clear, and typically blames others for their own failures. Shallow or defiant affect. This child may turn on or off their emotions and largely use them to manipulate or intimidate others. These characteristics have three recognized onset points: childhood onset, which is at least one characteristic prior to age 10, adolescent onset, which means no symptoms prior to age 10 and the symptoms onset by age 13, and unspecified onset, which means the onset of symptoms are unknown to the child's caretakers. Conduct disorder is also more common in children assigned male at birth than children assigned female at birth, and affects anywhere between 2% and 10% of children and adolescents in the United States. Research has been able to identify risk factors for conduct disorder that may include being male, living in poverty during childhood, having parents involved in criminal behavior or substance abuse, having family instability, specifically changes in parent or guardian figures, being a child who experiences harsh discipline and rejection from caretakers, associating with peers involved in criminal activity. These risk factors all show environmental and developmental factors that may raise a child's likelihood of being diagnosed with conduct disorder, but they are solely risk factors, not causes. Treatment for conduct disorder is multifaceted and involves treatment of comorbidities, family support, psychosocial interventions, and psychotherapy for many patients. Research has shown that therapies like functional family therapy, multisystemic therapy, and cognitive behavioral approaches, which focus on building skills such as anger management, to be successful when interventions occur early on. Examples of accredited evidence based psychological interventions for conduct disorder would include organizations like the Coping Power Program, a preventative intervention delivered to students in late elementary to middle school that uses skills based training to increase social competence, self regulation, and positive parental involvement, or parental child interaction therapy, PCIT, which is conducted through coaching sessions during which you and your child are in a playroom while the therapist is in an observation room watching you interact with your child through a one-way mirror or live video feed. You wear a bug in the ear device through which the therapist provides in the moment coaching on skills you are learning to manage your child's behavior. And The Incredible Years, a series of interlocking evidence based programs for parents, children, and teachers, supported by over 30 years of research. The goal is to prevent and treat young children's behavior problems and promote their social, emotional, and academic competence. The programs are used worldwide in schools and mental health centers and have been shown to work across cultures and socioeconomic groups.